Well, good morning. As the participants are all signing in now, as the room is opened, I'd like to welcome you to the third edition of the AO Trauma North America Internet Live Pelvic and Acetabular Fracture Management course. On behalf of myself, I'm Stephen Sims, the Chief of Orthopedic Trauma at Carolinas Medical Center in Charlotte, and Dr. Mark Riley from Rutgers University, New Jersey, and Dave Stephen in Sunnybrook Hospital in Toronto. We'd just like to say welcome, and we're happy that you joined us for today's course. Just as a reminder, this concept of the internet course was really born out of necessity from the COVID pandemic, which led us to have to cancel our face-to-face course, which would take place in the spring. It's turned out to be really a godsend because it has allowed us to really reach a lot more participants and to have the kind of faculty that we always dreamed about having at other courses. It was modeled after other successful courses, which most recently was the osteotomy course that completed a few weeks ago. We do plan to have a face-to-face meeting with cadavers, which will take place January 9th and 10th of 2021. It will be giving preference to the people who have attended the most courses, so most live courses on the internet with us. So if you can sign on as many times as you can, as the course fills up, you certainly will have preference if you attended more of those lectures. Lectures are recorded, and you will be able to get CME credit for it. Direct your attention to the YouTube channel, which is AO Trauma North America. You can find the previous lectures on that site and can find our current lectures there. Again, we commented on the faculty that we were able to assemble, and this really is an all-star panel of people that not only have a vast experience with taking care of pelvic and acetabular fracture injuries, but also have really distinguished themselves as excellent teachers in this discipline. So just to bring you up to date with where we are, this is our third edition on July the 25th. We've covered the first 2 weeks on pelvic ring injuries. And this ordinarily would be our small group discussion, but today we'll have an expert panel that will basically present cases, and we'll have an opportunity for you to ask questions to them. This is the expert panel that will be speaking today. We have Richard Jenkinson from Toronto, Matt Carnacher from Charlotte, North Carolina, Hans KREDER from Toronto as well, Chip ROUTT from UT Houston in Texas, and Mike Stover from Northwestern in Chicago, and Ray Wright from the University of Kentucky. So really we should be an outstanding group of people with some very interesting cases that will really emphasize and bring home some points. These are their disclosures. Our objectives today will be to demonstrate the key principles that we've really discussed in the previous 2 weeks on pelvic ring injuries by presenting 6 cases that will bring home these points. We will reinforce the need that you need to be able to apply many different strategies for the treatment of various different types of pelvic ring injuries. And it's a chance for you to kind of understand the thought process of the experts that will be speaking today and what they were thinking as they treated these injuries. As a reminder for Zoom etiquette, your microphones have all been muted and turned off. Just to emphasize that we encourage you to enter questions, to type them in. Use the Q&A tab, question and answer tab. There is a chat tab. If you use that, the questions probably won't get answered. So make sure you use the question and answer tab to ask your questions. Those questions that we feel would be better specifically answered by the presenter of the case, as they will be presenting their own cases. We'll save those for them to answer directly back to you, and some of them will be answered as just sort of generic questions. So with that, we will get started. I'll allow Dr. Jenkinson to share his screen, and he will present the first case, which I think will allow us to get an excellent start into this with something maybe you could think of as a more basic injury type pattern, but I think it will bring home some very interesting discussion and some points. So Richard?
Great, so my screen's being shared okay?
Yep, looks great.
Perfect. Well, good morning, everyone. So as Dr. Sims just said, this is a good bread and butter kind of case that anybody treating any volume of pelvic fractures is going to see with some regularity. So some things that we want to look at today is a few of these learning points about roles of binders, how to deal with some initial hemodynamic instability, we'll look at the images and how we go through this case in terms of deciding on fixation and post-op. So this is a case of a 58-year-old man. He's a hay farmer, previously healthy, elevated BMI, and this is my case from Toronto. So there are a few cowboys around, not just Dr. ROUTT's neck of the woods. He's riding on his horse on a farm, and the horse is spooked and he's bucked off. He presents to the trauma bay. He's awake and responsive. He's fine from an airway and breathing perspective. His circulation is abnormal. He's got a high heart rate and a blood pressure that's lower than expected. His FAST is negative, and this is his initial pelvic x-ray. So just take a second and look at that and think about what might be the problem and how you would deal with this. So when I look at this, it's quite obvious the anterior ring is disrupted through the symphysis. There's quite a bit of diastasis, several centimeters. And if you look at the posterior ring, the SI joint, particularly on the left, is disrupted, and the right one might not look normal either. So what are we going to do at this stage for a patient who's hemodynamically unstable with a pelvic ring, which seems to be the main culprit? So as we learned in the talks, the next step is probably going to be something to help with volume control. So the main options for that are the sheeting technique, which we saw in the lectures, and then a pelvic binder. These are a couple of the commercial pelvic binders, which are being used very regularly now. And just a point on how these are applied. So it's quite important to remember that the greater trochanters are the position where they need to be centered. So the green arrow is pointing to where the binder is basically pushing on the hips to collapse the pelvis back to a normal volume via the hip joints. And it shouldn't be centered on the iliac wings, because that will be ineffective and also tend to slip up and around to the patient's abdomen and not be very effective. So don't do that. So this is the patient after he's in a binder. So you can take a second there. You can see the binder artifact on the x-ray. And we can see the patient's closed down quite a bit. So at this stage, you've got to think, if this patient has not been fully resuscitated, if they haven't responded, what would be some options to manage that? So probably the binder could be retightened and improve the reduction. In terms of other things, in the past, in some places, maybe even still, an acute external fixator is considered. I'd say in most jurisdictions, a separate trip to the operating room to apply an external fixator is not in most people's resuscitation algorithms anymore. I'd say that's something that's not done in most jurisdictions. If the patient's going to the operating room for some other reason, then that could be consideration. And as we learned the other day, a resuscitation screw to close down the posterior ring may be appropriate if the situation's right in terms of the patient, the surgeon, and on the team factors. So this is the inlet-outlet views for this patient. So you can take a second to look at those and evaluate the injury again. You can see the pelvic ring is, as I've mentioned, not fully closed down. The left SI joint, I think you can see very well on the outlet view, is clearly widened compared to the other side, which looks pretty close to normal on the right. And the inlet view confirms that as well. So the next step would be to get a CT scan. So as I mentioned, the patient responds to the binder and the blood transfusion. So despite not being fully closed down, the patient hemodynamically stabilized after this initial reduction maneuver. So here's the CT scan. So I'm going to take a look at this and evaluate as we go through. I think we'd agree that the pelvic reduction looks quite excellent in the CT scanner. A little bit of an increase in the left SI joint in terms of not being completely normal. And now we're getting to the symphysis. And I don't know what you people think, but from my perspective, the symphysis looks quite a bit better in the CT scanner than it did on those, even the initial bound x-rays. So here's a few sort of isolated cuts. You can see the SI joint. Another thing to notice is this patient has quite favorable anatomy for iliosacral screws. He's a large patient, and he also has large corridors at S1 and S2. Perhaps there's a little vacuum phenomenon in the right SI joint just to be aware of. Maybe there's something more there than the CT scan would suggest. Here's a 2D recon. And here's a scout view when he was in the CT scanner. And I think we'd agree that this looks quite a bit better in terms of reduction than the plain films I showed you a few seconds ago. And this is something that's been noticed by some of our faculty. Dr. Riley and his colleagues wrote this up, showing how just the act of placing the patient in the CT scanner, having them positioned for that, it tends to reduce many people's pelvic rings, especially when they have a rotationally unstable injury through the symphysis such as this. And you have to be careful because some might actually reduce to the point where you're not as worried about them being unstable. So if you were to look at just the CT scout image and didn't have the benefit of the previous injury films, you might be even thinking this patient might have an APC1 injury, when I think it's quite clear he has at least an APC2, and some people may even consider it an APC3 based on his first films. So how are we going to treat this patient? We know that he's got at least the APC2 injury. So we know the front needs to be fixed. So here's some intraoperative X-rays showing the pelvic plate going on the symphysis, a retractor holding the bladder back, a little K-wire and a clamp holding the reduction. And this is the plate I tend to use, which is a specialty pelvic plate, which is built up in the middle and a bit more bulky than a standard pelvic recon plate. The advantage of this plate is it's nice and heavy, has a tendency not to break. One problem though is it's hard to mold to the pubic tubercles, so it pretty much has to sit a little more posterior than maybe optimal if you're going to try to get those long screws down the inferior ramus. So some of the faculty prefer a more malleable plate, but my experience with that is sometimes it breaks in the middle, and I don't like to see the plates break, so I tend to use the bigger one personally. So we fixed the front. It looks pretty reasonable. And now we have to decide if this patient needs more fixation. So, we classify this as an APC2, and many people would consider this to be enough. We could finish the operation at this stage. It's become, clear in my experience, and then also some papers suggest that the pelvic ring acts as a unit, and if you fix one side, you're going to improve the biomechanics significantly by fixing the posterior part as well as the anterior part. A little bit like fixing a bimalleolar ankle fracture. It makes sense to fix both sides of it. So we can, this has been observed in a paper fairly recently, where they looked at a lot of their APC2 injuries. There were 134, and there was a much higher rate of fixation failure with the anterior only fixation than they did with even a single SI screw at the back. And the malunion rate was also higher with only anterior fixation. Obviously there's some selection bias. It's particular surgeons have particular patterns in this, but still I think this is valuable information suggesting that posterior fixation is something that should be strongly considered for many of these APC2 injuries. And just a quick word on anterior plating. Usually that superior plate is enough. There's a history of double plating symphysis, and in my experience, the bone from the front to back for that anterior plate is pretty unsatisfying. And in my opinion, a single plate with posterior fixation is the optimal fixation construct for most things. And certainly 2 plates and no posterior fixation doesn't add enough to really be a worthwhile endeavor. So this is evaluating the SI joints for this patient. It looks like the left side's reduced quite nicely. The right one I don't have pictures of, but it certainly reduced. So we put in 2 SI screws to support it. They were put in this order with the SI-oriented one to sort of help lock in whatever gap there might be to try to improve the closure of the SI joint, and then neutralizing that with a second transiliac transsacral screw. And again, is that necessary? There's a lot of suggestion that maybe 1 screw would be enough, but the patient with nice favorable anatomy, it made sense to me to make a stronger construct for him. Also quite a large gentleman, and I never quite trust the anterior plates when the patient's obese. So this is final images, and satisfied with that reduction. So then now what to do post-operatively. So, you know, there's not much science on this. In my experience, if you have a tile C fracture, they can be quite disastrous if they fail, and I want to be careful with that. So I prefer to keep the tile C fractures non-weight bearing. The tile B fractures, again, it's a bit of a dependency on the patient factors. Is the patient going to be compliant? Are they large? Is their bone fixation good? Is the fracture a bit more inherently stable or not? But usually I'll let them do some sort of protected weight bearing with crutches or a walker. This patient was a farmer and still is, and asked me when he could get back on his tractor. So that makes me a little bit more worried he's going to be less compliant. So I definitely asked for him to be 50% weight bearing on that left side, and weight bearing is tolerated on the right. This is a similar case, just to show some follow-up of something like that. This is one I did in the past where we just fixed the front and didn't fix the back. And you know, he did okay, but he went on to lose some fixation after a few months. Not enough to need revision surgery, but certainly, you know, it could have gone on to failure. And a certain number of patients with that injury and no posterior fixation might fail enough to need a revision. So I think my practice has evolved where I routinely put in posterior fixation for any of these APC injuries, and very rarely do not put that in, really only if there's very unfavorable anatomy for iliosacral screws. And you can see that bit of opening. So hopefully we cover these. So remember, the pelvic binder is a good first option for closing down the patient's pelvic ring. It should be centered at the greater trochanters. In terms of acute external fixation, so we talked briefly about iliosacral screws as a resuscitation screw. Another thing that could be considered is if this patient was a different scenario and went to the OR for say a laparotomy, if the situation is right, it's quite reasonable to go ahead with symphyseal plating if that's something you're comfortable with and the patient is in a reasonable situation. Certainly, for me, I can put an anterior plate on at about the same amount of time as an external fixator, and will be good for him long term. We looked at our images, and remember the inadvertent reduction during CT. Keep that in mind. You may need to have an examination under anesthesia or take post-operative plain or post-CT plain films to really be able to assess that patient to understand whether they will need surgery or not. And then posterior fixation is definitely preferred in almost all of these patients, in my opinion. So that's great. Hopefully that's been helpful for you.
Hey, thank you, Richard. That's a good case to get things warmed up and started with, while Dr. Stover is getting his case ready to roll. And you can go ahead and stop sharing yours, Richard, and we'll get Michael to share his screen. I'll just ask you one question while we're going to the next thing. Is there any role for definitive treatment of a symphysis dislocation with an external fixator in your practice?
Very limited. The stability you get from an external fixator is quite poor. So in almost all cases, I think the symphyseal plating is preferred. There may be some particular situations where patients had a bladder rupture and extreme infection, and you really don't want to be putting a fixation in. But in most cases, even with urologic injury, with a repaired bladder and a cleaned out symphyseal region, I prefer to put in a plate. And that sort of last case, the one with just the symphyseal plate, that was the actual situation for that patient, where we washed out and repaired a bladder injury and then plated the front. And that was an acute sort of emergency operation. And at that stage in my career, I wasn't quite ready to put in SI screws, and we just sort of didn't get around to it. But I think it's something I would do now.
Great. Thank you very much, Richard. There are a lot of good questions that came through. Some of them have been answered. Some of them are saved for you. So if you'll take a look at the question and answer screen, there's some good questions that you can get busy answering on now, if you don't mind. So with that, we'll turn it over to Dr. Michael Stover, who has a vast experience of pelvic and acetabular fracture treatment at Northwestern in Chicago, and will present something that's becoming more and more of a common problem with our aging population, including myself in that group, unfortunately. So, Michael?
Okay, so we're going to present a case on a 72-year-old female, simple slip and fall onto her backside. A week prior to presenting to the ER, she complained of tailbone pain. She has some inflammatory conditions for which she takes quite a bit of prednisone each day, history of osteoporosis on some bisphosphonates. And on presentation, she had some sense of urgency to urinate, but was unable. On the initial evaluation, she had no saddle anesthesia. Her post-void residual was less than 100, and she was discharged home with routine follow-up with her medicine physician. These are her x-rays from the emergency department. So if you look at these very closely, you'll see things a little bit more apparent later on. But they evaluated this, felt she had low back pain, and was discharged home with follow-up with their medicine physician. So a week later, she saw internal medicine. Now she's complaining of left groin pain, anterior thigh pain, difficulty walking, sitting, intermittent incontinence of bowel and bladder, felt like her left leg was giving out. So these are the x-rays that were obtained in the primary care office. They noticed now that she had a parasymphyseal fracture that you can see quite readily here on the left. They prescribed her a wheelchair along with her walker, gave her some narcotics, felt with her history of osteoporosis that they would have the endocrine physician evaluate her and send her to orthopedics for this fracture. In orthopedics, she was initially seen by a PA, and again now complaining of groin pain, now with pain radiating down the back of her legs to her knees. She was now incontinent of urine only, but she felt this was actually improving. She had a couple of episodes of bowel and bladder incontinence during the first 2 weeks, but she felt it was improving, and the PA ordered an MRI. So the MRI is here for evaluation. You can see that she has fluid signals within the sacral ala bilaterally. And so when you think of bilateral injuries to the sacrum, you should always think of a transverse component. So going to the sagittal section, you can see here at S2-3, she has a kyphotic deformity at S2-3 with surrounding hematoma consistent with a U-shaped sacral fracture. So she was sent to my clinic. She's now unable to ambulate with a walker or max assist. She had severe pain with sitting. So she was mainly at bed rest. She still had incontinence, difficulty with bowel movements, and in my evaluation had decreased rectal tone in the clinic. Here's our radiographs in our clinic. So now just going back, you can also see from the initial film, she has fractures of bilateral sacrum. You can see that there's a slight cranial migration bilaterally. Not really a deformity seen on the mid portion and the parasymphyseal fracture. Here you can maybe get a sense of the sacral foramina at S2 are a little bit distorted, consistent with that transverse pattern. Here's your parasymphyseal fracture. And then with the lateral of the sacrum, now you can actually see the displacement. So here's the kyphotic deformity, translation of about 50% of the sacral body. We obtained a CT scan to better evaluate the sacral canal, especially with her neurologic complaints. So the bilateral sacral ala fractures. You can see here at the transitional zone, there's the S2 deformities you saw in the plain x-rays. Here's her kyphotic deformity, maybe a little callus formation now at 3 weeks, with complete obliteration of the sacral canal at S2-3. So this is an axial reformat in the sacral plane to show us exactly the sacral canal. So her diagnosis is a sacral insufficiency fracture. The morphology is U-shaped, and she also has sacral nerve root compression and dysfunction. So what are your treatment options? I think in this circumstance, it does seem appropriate that she should be stabilized and that she can then be mobilized better. She's lost her mobility status, and also what to do with the neurologic components of her complaints. So our plan was to perform lumbopelvic stabilization with no fusion. There would be no reduction really because there wasn't significant deformity, and we would do a sacral laminectomy as a form of decompression of the sacral nerve roots, and we'd explore these. And for me, I actually get a neurosurgeon involved with this portion of the procedure so they can mobilize the nerve roots, and they also can help out if there's any durotomies or any traumatic injuries to the nerves. So this is our treatment that we prescribed, and this was performed along with the neurosurgeon. Due to her osteoporosis, we used augmentation within the lumbar bodies. Our fixation stems from L4-5, skipping the sacrum, and then using iliac bolts. We can use one iliac bolt. Initially, we used types of fixation here where these were fixed angle. These are actually polyaxial screws, and there can be some comments on that as well as part of the fixation, especially in higher energy injuries. Post-operatively, we prescribed protected weight bearing with a walker. We actually prescribed anabolic augmentation with teriparatide. This is an off-label use of a osteoporotic drug that can facilitate bone healing. These are her x-rays 6 months after surgery. She has a resolution of her neurologic symptoms. She has intermittent stress incontinence, control of her bowel and bladder for the most part. She has no pain except for occasional lower back pain, which I think is probably associated with the stabilization of lumbar spine without fusion. And she went on to do quite well. So here you can see CT scan proven healing or union of the sacral fracture, with our plans then to remove the implants that were canceled due to the COVID issues, and she still has her implants in place. So her diagnosis is a U-shaped insufficiency fracture. So with these fractures, your role of stabilization is probably in those patients that have inability to mobilize. Some fractures are actually inherently stable due to the compression that occurs with the fall, and they can be mobilized, but they just have to be followed very closely for any progressive displacement or neurologic dysfunction or inability to mobilize, and therefore you may have a role for stabilization in those patients as well. Early on, there can also be a role for the possibility of transsacral fixation that's been published before with Dr. ROUTT's paper. That doesn't necessarily apply yet to the osteoporotic population or how it performs in that population. The reduction is difficult in the setting of osteoporosis or really in any circumstances. Early on with the initial injury, with higher energy injuries, I use a table with hip hyperextension and stabilization of the pelvis to get a postural reduction. Direct reduction can be very difficult, especially in higher energy injuries, but is maybe indicated with wide displacements or spinal optasis. This is very difficult though, requires a laminectomy. You can use the pedicle screws above to the iliac bolts below for distraction. You have to then move the pelvis back up onto the sacrum while pushing the sacral body down. The construct, as mentioned, is typically L4-5 with iliac bolts. Usually one is fine if you just put this right above the greater sciatic notch so that there's a good buttress against the notch, or a stable buttress against the notch to limit flexion deformity and also rotational deformity through the screw. With fusion, I don't think there's any role for fusion at the lumbar segments, but you should consider fusion at L5-S1, especially if the lumbosacral facets are involved, as these can be a pain generator in the future. And there's really minimal loss of motion at the L5-S1 junction for most people. And then plan for removal of implants at 6 to 9 months following stabilization. So that's a case of insufficiency sacral fractures, not a high energy, but we see it more often. I think the point would be, if you have a patient, low energy injury, lower back pain, really look at their initial x-rays for a sacral injury. If it's not apparent on the plain radiographs, MRI has been utilized a lot in our institution to diagnose the insufficiency fractures, the posterior pelvic ring. If you see bilateral injuries, always be really hypervigilant to look for a transverse component. And as you mobilize these patients, be careful as to monitoring for any further displacement, inability to mobilize, or sacral nerve root dysfunction. Thank you very much.
Thank you, Mike. That's a fascinating case. So you can go ahead and stop sharing your screen, and we'll let Dr. ROUTT start getting his screen up ready for the next presentation. But the question, there have been several questions, so you can address some of those as you finish. But can you describe the approach that you use for that surgery? Is it a midline exposure with undermining out to the to get to the crest, or what is your approach?
Yeah, so in the patient with a plan for a sacral decompression, I think you have to go through a midline approach, at least through the distal segment. So we do a midline approach and mobilize the erector spinae muscle out to the base of the posterior superior iliac spine, and just below that is the insertion of your iliac bolt. If you're doing a unilateral sacral fracture or bilateral sacral fractures in a higher energy injury, you may choose to do a posterior approach to the pelvic ring and extend that up into a Wiltse approach to give you access to the pedicles.
Great, thank you, Mike. So the next presenter will be, as Mike gets busy answering some of the questions that came through, will be a case of a very complex displaced sacral fracture with anterior ring injuries as well from Dr. Chip ROUTT. So I think this will be a very interesting case. So bring it forward some great points. So Chip, we'll turn it over to you.
Hi, Steve. Thank you all. Greetings from Hurricane Hannah, and we have pandemic and we have hurricane today in Houston. So hopefully I'll have power for the rest of my 12-minute assignment here. I've been asked to go through an unstable pelvic ring, and I hope you'll be able to easily identify the diagnosis on the patient that I'll show you. And I think the initial management has gone over so well. In our patient, it's a little bit different than all the initial management patients you've seen so far. She's going to be hemodynamically stable throughout her initial management, and she's never really even going to have much tachycardia, so we don't have to worry so much about that. More specifically, we're going to just focus on the imaging, and we're going to try to use the imaging details to help us interpret what we would do as far as the decision making. And I'll try to focus mostly on decision making and the preoperative planning, and then I'll carry you through for about a 7-year follow-up now with a 4-year radiographic follow-up. So I'll just present you with a 24-year-old female who rides a moped in order to save money. She's putting herself through college. She's in the last year of college. Her mother's a nurse down the street at an ICU. Just a very bright young female, got hit by a car. And you can see very easily that her symphysis pubis is completely disrupted. The left ramus is fractured and completely displaced. And then you can easily identify, I think, her right transforaminal sacral fracture and the displacement of her right hemipelvis cranially on this film. And then it almost looks like an obturator oblique of the right side. So you get a good idea of the violence of injury of this right hemipelvis. And I'll just tell you the left hemipelvis is going to be okay. So the injury details present very quickly to us on the plain film, and I think it's always good to cheat and look at the plain film first off. Her past medical history is irrelevant. She's on no medications, and in reality, that's a radiographically obvious unstable ring, and so we don't have to go pushing on this or feeling this for mechanical instability. It's obvious on the x-rays. So still, though, perhaps a little bit of a volume expanding, and so you may want to consider doing some things to her. If you look at her 3Ds, you can see on the inlet surface rendered image, she's got a nice anterior iliac, sacral border, and you can see the deformity and displacement through the sacral area, as well as the symphysis pubis and the left ramus fracture. The Z shape of the ramus is a good thing. You can also see on the outlet reformatted image that the fracture may leak up into or extend into the 5th lumbar vertebra area. Look at the comminution around 1 o'clock, 2 o'clock on the S1 tunnel exit area, the foramen. You can see some comminution there as well. And again, you can see the deformity of the right hemipelvis. The oblique views we don't use very much, but in this instance, it's a great look at the surface of the fracture plane. And you can see the two surfaces very well. You know, if you were a clot remover and a reducer, you'd really want to get right into that plane of the sacrum to put those two back together. And then I like the posterior view a lot just to look at the cortical details of the surface of the dorsal sacrum to see exactly how comminuted it might be. If I choose to maybe do an open reduction on this, where would I set a clamp? Should I dock it in the ilium on the right side through a drill hole and then down around the spinous process of the caudal sacrum? Could I put a clamp on the caudal exit point of the sacral fracture? How cranial can I get with my dissection, and how deep does that dissection get? What are the interdigitations of the fracture? How relevant will they be to me to help me identify an accurate reduction, whether I'm doing it closed or open? And then again, the posterior oblique view, just to look down the plane of the surfaces. I love these views to help me see the fracture surfaces that I might need to get into and then imagine what would be in that area besides just the hematoma. The axial images will show you the dysmorphism of her upper sacral segment, that little bit of comminution at the nerve root tunnel you can see on the upper left there. The second axial image just shows the patency of S2 and the anatomy of S2, or the second sacral segment. And then the parasymphyseal film there, the axial image shows the symphysis and the ramus. And then again, you can see on the sagittal, she's got a pretty good inclination of her upper sacrum, so you can plan her inlet view like we talked about 2 weeks ago. So I don't really think she needs a bunch of other evaluations. She's hemodynamically stable. She's neurologically normal. We certainly want to do a detailed neurological exam. And then I think for her, this may be a great patient for traction to try to help improve the reduction of this. And then we mostly just have to figure out what we want to do and when we want to do it. And luckily for us and for her, she's never really been sick. Her soft tissues are in great shape. She doesn't have any abrasions. She doesn't have any identifiable ecchymoses or contusions. If you look back to her axial images, her soft tissues don't even look like they have soft tissue degloving injuries. You can see on the upper left axial image the contrast in the vessels. The hematoma in the area of the sacral fracture doesn't seem to have much contrast in it. So again, not really a difficult physiological patient to take care of, but maybe a structural problem for a rebuilding. In the operating room, I think it's always good just to see what the paralysis or what the anesthesia does to the patient. And here's just some plain images, an inlet and an outlet image of the sacrum with her just in 15 pounds of traction supine. And I think in 2013, the way I handled this would be a lot different than the way I would handle it in 2020, because in 2020, we have devices now in the operating room for the last 4 or 5 years where we can do with the fluoroscopy advanced imaging to see the value or the alignment of this using closed techniques. And we can get an idea if we want to use closed reduction techniques and percutaneous fixation, or if we want to proceed to open reduction. I thought this was a pretty good closed reduction, but again, I was limited by the fluoroscopy that I had in 2013. So we have to decide, are we going to do an ORIF of the anterior pelvis first and then just close reduction to sacrum? A lot of people like that. They say it's minimally invasive. It avoids the soft tissue complications of the posterior pelvic ring, and that's okay. Maybe close reduction of the sacrum and anterior X-fix. That would be even simpler to do, but maybe not as structurally sound. The X-fix is not so mechanically efficient. And then maybe close reduction of the sacrum, ramus and the sacrum, and then plus or minus an X-fix. Or we could do prone operation. We could turn her prone and do ORIF of the sacrum first, with or without level pelvic, because remember we had the fracture extending up into the L5 area. Or prone ORIF and then turn her over and do supine, anterior X-fix, or ORIF. So a lot of different options. We chose to do prone. We left her in traction, although this is an unstable fracture. I don't think you necessarily have to use traction at all. I don't know its value because it's an unstable fracture. We did a direct dorsal approach, so we could see that fracture plane, see the cortical dorsal edges, clean them, reduce it, and then clamp it. And if you practice with the imaging, you can start to sort of ghost in these modeling, so you can use what you may see during the surgery while you're doing the dorsal approach. And we did a direct dorsal approach. Once we were able to see this and remove the hematoma and the local tissue, we were able to clamp, and we did use a caudal tenaculum clamp first, just to get the length at the area of that exit. That's a really broad surface, densely corticated surface, to put our first medium tenaculum clamp, and then a subsequent clamp a little bit more proximally. And then we used a summary clamp in the operating room just to get both vectors, so we could restore the length and also the reduction, and we could summarize that with just an oblique clamp like you see there in the operating room. And then we went ahead and used iliosacral screws to accommodate the pathways. The fracture is clamped, and so we used fully threaded screws at the cranial site, or the upper sacral segment. We put 2 individual screws, and then at the second sacral segment we used a transsacral screw, and then turned her over, did a low midline approach, and I tried to do a ramus screw on her. We did an open reduction of her ramus and clamped it, but she's a little bit curved for a straight screw, so we used an intrapelvic type of plate and then plated up her symphysis. You can see her symphyseal area, the bone in that area is kind of frail. Someone earlier asked, well, do you use 2 plates a lot? We don't usually use 2 plates because the mechanical advantages in the lab weren't really realized in the people. And then you can see here when we combine plates, sometimes there's not a lot of room along the symphysis to dock 2 plates. You could have also made the intrapelvic plate just go to the opposite side as well. You can contour the plate for that. And I think y'all have seen some examples of that. So we thought that this was really good for her pelvic component, but again, not so much for her spine component. The person that helps me with spinal pelvic or lumbopelvic fixation was actually at the American Academy meeting during this time. And he came back 2 days later and then went ahead and fortified her fixation construct to include this. He does percutaneous lumbopelvic. And so he didn't have to reopen our wound or anything like that. It would have been a whole lot better to have had someone in town and coordinate that through the first operation, but it wasn't possible. With percutaneous lumbopelvic, they can slip these in under fluoroscopy and do the work that's necessary. Dr. Stover was already talking about. Postoperatively, we allowed her to have full weight bearing, on her uninjured side on the left side, and then we allowed her protected weight bearing on her right side and just did some isometrics. The isometrics and the stretching and the light aerobic is, I think, important for the first 6 weeks, and then after that we let her sort of cut loose. This was her last film at 4 years. She had graduated college, full-time employment, did every activity she wanted, refused her hardware. She didn't have symptoms related to this. And then she plans on having children. She's married and plans on having a family. Of course, no obstetrician in North America is going to allow her to have a spontaneous vaginal delivery. But that's the extent of this injury. And the reason we chose what we did was, when I opened this fracture, at the time we did the open reduction, it didn't have this much displacement at all. This fracture was maybe 4 millimeters displaced with her asleep and prone. And when we went to put this clamp on, and so the amount of displacement that we had visible to us on the fluoroscopy views intraoperatively was pretty real. And it's as close as it looks there, but still probably 4 to 5 millimeters off. And I think the open reduction helped us to improve the contact, helps us to improve the reduction, helps us to get a better stable fixation, also to restore those conduits of fixation like we talked about, so the screws are safer and give us less deformity. So thank you very much for your attention. I hope that this patient's example has brought up some good reflection points for you and discussion points for later on.
That's a great case. I'm sure we could spend the next hour and a half talking about this one if we wanted to. So many different treatment choices, but could you, there were several questions about nerve roots, and in the last case we saw where there was a laminectomy done to decompress the nerve roots. Could you talk about
Sure.
about that for this case, the nerve roots, and whether you think anything else needs to be done there?
Yeah, so her nerve roots were all normal. So she didn't have any nerve problems at all. And so all we're doing is reconstituting the tubes. One of the reasons I like open reduction for transforaminal sacral fractures, if there's identifiable debris that's accessible, we can just fetch that debris during the course of the exposure. If it's way anterior, like hers was way anterior and up in the, like that's why I sit up at 1 o'clock to 2 o'clock on the anterior cranial aspect of the tunnel exit point. And with her being neurologically normal, with the open reduction, it makes those tubes go back together. That's the beauty of open reduction. The tubes are coming back together anatomically. And so I don't see any reason to dissect out nerves or try to look. You can see them in the wound sometimes, but I don't think there's any reason to go after nerves or things like that. And I believe open reduction is a really good thing because it puts the tubes back together. Or those nerve
the open reduction basically does the decompression for you almost, basically.
Yeah, it just puts the nerves back into it, puts the tunnels back together appropriately. And
then Chip, maybe one last question before we get Dr. Carnacher on this next case. Can you, this may be an unfair question. If it's going to take 30 minutes, you may have you type it in, but I don't want to ask you something that's too difficult to answer briefly. But can you give us an idea when you think an open reduction for a sacral fracture is necessary?
When a closed reduction,
in your practice,
when a closed reduction is insufficient. So if you, and with the advanced imaging we have right now, we can assess that really well in the operating room. So if you have a reduction that's totally insufficient with closed techniques, then you just need an open reduction. People try all these different manipulations with beds and tools and all these outriggers, and they just need a knife. You need a knife and some retractors and some clamps. So some fractures, you just shouldn't work for hours trying to get a closed reduction. You just open them, clamp them, put them back together.
So you start out supine and go through some traction and maybe some maneuvers to see if it reduces, and if it doesn't, then you would turn them prone and do an open reduction.
Yes, I would have accepted this closed reduction if she had had any type of issues, if I couldn't turn her prone, on whatever it is. Some people, I can't, terrible abrasions, bad, terrible soft tissues, things like that, I might have gone for closed reduction, but this is just an insufficient closed reduction.
Great. I'm sure, Chip, there's going to be a lot of, there are a lot of questions coming in. So if you'll take a look at the question and answer session, I appreciate you can answer some of the questions. Great case, and thanks for going through that. So our next speaker will be Dr. Matt Carnacher from Carolinas Medical Center in Charlotte, who's going to present, I think, a very interesting case with some soft tissue issues that really play an important role in the treatment, and things that have been many questions asked about already. So Matt, we'll turn it over to you.
Okay, so this is a 17-year-old female who was involved in a motor vehicle accident. At her time of injury, she had an open femur fracture, the pelvic fracture that you see here, and she was subsequently transferred on post-injury day 3 to our facility for management of the pelvis. I think anytime that you are initially evaluating a patient, you need to take a look at the films and take a step back, and this is clearly a lateral compression type injury, and we heard earlier in the lectures about associated injuries, including head injuries, abdominal injuries. Fortunately, this patient didn't have either of those. When she presented, she had some hemodynamic instability, and you can see a coil where she had a embolization of the obturator artery. And while not uncommon, you can have injuries to the vessels in a lateral compression type injury. You can see she's in traction for when she was transferred for our pelvis. Here's some further imaging, and when we look at this imaging, try to be systematic in your evaluation. We start first with the right SI joint. It doesn't look too bad on the images. And then we move over to the left side, and on the left side we can see the fracture of the iliac wing that extends up to the SI joint, has a segmental component to it. The rami fractures in the front on the left side, a relatively simple fracture of the superior and inferior ramus, and on the right side, a very comminuted fracture of the parasymphyseal region. When we look at the anatomy of the sacrum, there doesn't appear to be dysmorphism and no additional sacral fractures. You can also notice that the hip looks a little bit distracted on the left side, so the patient is in traction, and this is how she was transferred. So then we go to the CT imaging. In similar fashion, you can see the comminuted anterior ring and the left pubic root rami fracture. See the iliac wing fracture, and you can see here where I stopped it that the fracture really is a little bit anterior to the SI joint. So this is important in your operative consideration that iliocecal screw by itself will probably not be adequate fixation for this fracture, and that you would either need to address the segmental component or have some sort of fixation from the inferior spine into the posterior fragment. So our initial plan was to take her to the operating room and address the posterior ring, starting with the left side, and address the segmental fracture component through an open lateral window, and then examine the right side, because it's not unusual with these bad lateral compression injuries to have an external rotation deformity of the right side, and then follow that by assessing the anterior ring. On the day of surgery, however, she spiked a fever to 105. This is her second hospital day, post-injury day 5, and obviously we were concerned about this. So ordered a CT scan, and you can see on this CT scan that there's an abscess in the labial region, and there also is a retropubic abscess. And then on this image, you can see an abscess in the adductor region. So she had adductor, labial, and retropubic abscesses, and this obviously was concerning and changed our plan. If you look at the initial CT that I showed you from when she was transferred, you can actually see air in the area around the pubic rami and in the labial region. So it's likely that this patient had an open pelvic fracture that was not identified at the time of injury. And it turns out when we took her to the operating room that she did have injury in the vaginal wall. I would like to take a minute to just discuss open pelvic fractures. This is a little bit unusual in this circumstance in that it was identified in a delayed fashion. I think one of the important things is to use all the information that you have on your initial evaluation of the patient. So clearly you can see air in the soft tissues. That should have been a warning sign that there's a risk of open fracture. Having a complete examination, including a vaginal exam and a rectal exam, is critical when you have these significantly displaced pelvic fractures. When you identify an open fracture, this is, I think it's very important to have coordination with your care with the general surgeons and potentially with the gynecologist. And in my experience, most of your colleagues will not have a lot of experience with these injuries. So they're looking for you for guidance on what to do. And I would recommend very strongly, in addition to coordination of care, being very aggressive about your initial management. And the initial management should be a very thorough debridement and trying to close when possible the wounds. If there's a injury that goes into the area by the rectum or in the perineal region, to have the conversation with the general surgeon about diverting colostomy. So in this case, we took the patient to the OR with the help of the gynecologist and went with for an IND of the thigh, the adductor, and the labial abscesses. And we started first with looking at the vaginal region and then the thigh, and then performed a symphyseal fan steel type of approach to decompress the retroperitoneal, the retropubic abscess. And during that exposure, identified a extraperitoneal bladder rupture. So at that point, we consulted urology, and urology came in and did primary repair of the extraperitoneal bladder rupture. So this gives us another opportunity to discuss associated injuries. Bladder ruptures probably occur about 10% of the time in pelvic fractures. Extraperitoneal bladder ruptures are more common than intraperitoneal bladder ruptures. From a urologic standpoint, if a catheter has been passed, a Foley catheter has been passed, urologists frequently will say that they don't need to do anything with these injuries. However, if you're considering fixation of the anterior ring, it's important to coordinate with them, and at the time of your anterior fixation, they can often repair the extraperitoneal bladder rupture, and then you can proceed with your operation. A little more complicated situation would be if you had a urethral injury or a suprapubic tube, and in that case, again, it's critical to coordinate with the urologist in terms of management of the suprapubic tube. In general, we try to ask for the suprapubic tube to be moved off of the midline, off to a side somewhere, and as proximal as possible. It is possible at times for them to pass a catheter and then have the suprapubic tube removed or exchanged. But again, it's important to identify these injuries and then also to have good coordination with your consultants. So in this particular case, after we performed the IND of the abscesses and had the bladder repaired, and you can see the drain on the image, the question is, do we need to perform some other fixation, temporizing fixation, such as an external fixator, while we wait for definitive fixation and the timing of definitive fixation? And as I mentioned, the films earlier were demonstrated that the fracture was reasonably well aligned. There's still internal rotation deformity in traction, and appreciating that we were going to come back and do repeated INDs, and elected not to, but I think you could make an argument for supplemental fixation with an external fixator, but I think the traction was helping. So the plan at this point was for repeated INDs. We performed 2 additional INDs, and then to proceed with internal fixation. As I mentioned, the decision for stability on or fixation on the pelvis, the decision was made to move more with the posterior fixation first, as the anterior ring was very common, and it was not felt that this would help that much with reduction. So lateral window was was performed, and open reduction was performed with a segmental fracture component with plates and screws, and then a screw was placed down the inferior spine quarter. At that point, there was some external rotation or displacement of the left sacroiliac joint, so iliocecal screw was placed. And intraoperatively, there was displacement or external rotation of the right hemipelvis, so a right iliocecal screw was subsequently inserted. If you identify the external rotation of the right hemipelvis or the contralateral side in these lateral compression 3 type injuries early, I would typically fix that first to have a stable base, but this was something that was not really identified till we were able to stress the fracture. So after we stabilized the back of the ring, the debate then is what to do with the front of the ring. And as you could see from the initial injuries, the left ramus was relatively simple, could have probably fixed that with the screw. The right ramus was quite comminuted, and it was not certain that screw fixation would be enough. Another option is external fixation, particularly in the face of the prior infection and multiple debridements. That would have been a very reasonable option. However, given that the exposure was already there from the debridements, and I felt that having additional stability would help with the tissue healing with such a large tissue injury, I decided to go ahead with internal fixation. And I think this is a little bit different in the pelvis than you'll hear about later in the course in the acetabulum. In the pelvis, I think you can be a little more aggressive with internal fixation, because if you get an infection, it can often be treated with repeated debridements and salvage of the hardware like we may perform in other parts of the body. However, in the acetabulum, in contrast, if you get an infection in the hip is gone. So while you have to be concerned with the bladder injury and with the prior infection, I think providing stability was a trade-off for that, and that's what we elected to do with in this procedure. And then these are just follow-up films. Patient came back at 5 years for questions about the heterotopic bone that had formed on the lateral side of her femur. You can see that a little bit there. She had a bad open femur fracture. Was doing well from her pelvis, did not have any signs and symptoms of infection, and also had some questions about pregnancy, as she was now in her 20s. And similar to what Dr. ROUTT already mentioned, we had a discussion that no OB-GYN would allow her to progress through a vaginal delivery. So in summary, I think this case demonstrates a couple of important concepts. First is that you need to thoroughly evaluate your patient and injury. Use all the information that you have, perform a complete physical examination, including the vaginal, perineal, rectal exams. Review all the diagnostic studies. There can often be a lot of information on those studies. Looking at the soft tissue windows, noticing if there is hematoma, blush, air. Be aware, recognize the injury patterns, be aware of associated injuries. In this case, we saw hemorrhage from the obturator vessels. We saw a bladder injury, an open wound. And if you identify these, it's important to manage these injuries aggressively, because I think that's the most predictable way to ensure improved outcomes. Thank you.
Great, thank you, Matt. That's a fascinating case, and as you can imagine, there are multiple questions coming through about plating in the presence of an infection that occurred there. I'll let you answer some. I think you answered most of those in your talk, but you can go through and answer some of those again. Let me just ask you the question that comes up quite regularly, which is, does the presence of a suprapubic catheter prevent you from doing anterior plate fixation? And if you do proceed with that, how do you manage the suprapubic catheter during that surgery? How do you deal with the urologist?
Yeah. So I think a lot of it has to depend with your urologic team. Unfortunately, in our center, we have urology available on a regular basis. So I think, as I mentioned, having a discussion with them in advance about the possibility of removing the tube and passing a catheter, repairing whatever injury, or if they can't, tunneling it away, So in most circumstances, I've moved forward with fixation with urologic assistance in the operating room. But I think it'd really be dependent on how much they feel they could move it or take it out, and what your urologic support is, and how valuable the fixation would be in the front for your overall construct.
Great, thank you, Matt. There are lots of questions. Yeah, I think it seems like the problem is if you do nothing for fixation and keep putting it off until you think things are perfect, then you end up with a situation where you had the same infection to deal with, but you end up late enough in the process where correcting the pelvic deformity is extremely difficult. And the ones I see that are most complicated are the ones that have these horrible malunions or very delayed reduction and fixations, and had bad tissues and infections that were left open and dealt with in a different way. So I think your technique of being very aggressive with debriding wounds and repairing bladders and moving on with things as quickly as possible and trying to get fixation in is probably the right way to go. Great, thank you, Matt. Appreciate it. That was a great case. So next speaker will be Dr. Hans KREDER from Sunnybrook Hospital in Toronto, one of the seats of the historical pelvic treatment, and he's going to talk to us about kind of a specialized fracture configuration that may require some different thought processes. So, Hans, I'll turn it over to you.
Great, thank you. Greetings, colleagues and friends from Toronto, where it's nice and sunny. This is a fairly quick case to go through because I just wanted to make a few points. Most of the fractures that you'll operate on in the pelvic ring are for instability. That is, the pieces are moving, you have to stabilize them. This is a bit of a unique case that isn't a case of instability. It's a case of deformity. So this is a 26-year-old. She was on the back of a motorcycle that her boyfriend crashed. She ended up falling over with a motorcycle. Just have a look at her clinical photos there. The burns on her ankles are from the tailpipe of the motorcycle. And just think about which side you think is the problem side. She doesn't have a lot of pain, and if you examine her pelvis, it's really quite stable. You can crank on it and it doesn't really move. She really isn't complaining much of pain, and there are her clinical photos. And if you look at the spine, it looks like the pelvis is fairly, it's a little bit rotated, but it's not as rotated as the hemipelvis on the left would indicate. That hemipelvis is really quite significantly internally rotated. She's got parasymphyseal fracture on the right, on the opposite side, and a high pubis fracture on the left. And, when you look at the level of her hip joints, the left side is cranially displaced and clearly internally rotated relative to the right side. So in fact, if you go back to the clinical photo, it's the left side that's the abnormal side. It's internally rotated and shortened. And here are the volume rendered inlet and outlet views. You can see, among other things, some dysmorphism, but the important thing is the internal rotation of the left hemipelvis and the cranial rotation. So it's not a symmetric compression just from the lateral side. It's an asymmetric compression where the hemipelvis is rotated cranially as well as internally on the left side. And here's a representative cut on the CT scan. And again, you see the internal rotation on the left side. And I just want to emphasize that this patient's pelvis is clinically stable, the right side. Very importantly, you've seen, the last case where there were bilateral injuries. This right side is completely stable. She doesn't have much pain on either side. And when you think about this, here are sort of the thoughts that you might want to think about. If this was a geriatric patient with a stable pelvic ring, you might say, well, she doesn't have much pain. What's the downside of just having her carry on? Maybe restrict her weight bearing a little bit. And then, you might think about whether to reduce this deformity and to fix it and how you would do that. So again, here's the preoperative internally rotated and shortened left leg. And here is a picture from Dr. Tile's book on the pelvis. And this is called a bucket handle lateral compression, or this is one of the names that's been applied to this asymmetric type of compression. It's like the bucket handle goes cranial and medial, and thereby you shorten and internally rotate the leg. So here again, what's your management plan? My management plan was that I was going to reduce the short internally rotated leg on this 26-year-old young lady. It wasn't surgery for instability. She doesn't have any instability, but it was to reduce the deformity. So when you look at that, I'll just give you a moment to sort of contemplate how you might reduce that. And then once you reduce it, now the pelvic ring is going to have some mobility to it because you've taken it from a stable, impacted position. You're going to disimpact that. You're going to now have some instability, biomechanic instability of the pelvic ring. How are you going to maintain that reduction? So here's what we did. This is a clinical photo, and sometimes you can augment that. And I usually try to do this before sort of prepping and draping, but you can augment that after you've got a bit of a reduction. You can augment it with some fixation into the anterior inferior iliac spine and put a Schanz pin in there, 5 or 6 millimeter pin. It has to be quite robust because this takes quite a bit of force to reduce, and that can be a way of augmenting your reduction maneuver. And this is her, the pre-reduction and the post-reduction. This is before prepping and draping and so on. Just, you can see that certainly the rotation has been improved. Maybe she's still a little bit short. So this is the pre and post-reduction film. And my strategy on these is to distract with a fixator. Now, you can see that we've used bilateral anterior inferior iliac spine corridors and used a distraction type of frame there. And you can see that there's still some malreduction or incomplete reduction of that left hemipelvis internal rotation. Some people like to put a gluteus medius pillar pin in on the right, with the idea that that vector is more in line with the cranial displacement and the medial displacement. And I've done that, but I find the anterior inferior pins are a little bit more robust and a little bit more well tolerated by the patients when they mobilize. And I'll show you a clinical photo of this young lady in a minute. So that was my strategy, distraction. And I didn't think in this particular case that the disimpaction in this 26-year-old was going to be a big problem. But I'll show you another case here where this is a different case, much more significant injury. And and this is my case. This wasn't a colleague's case. This was my case early in my career in the first few years. And I recognized that I'd created a gap and that there was instability. I used that asymmetric type of, in fact, I just used gluteus medius pillars at this time. But you can see that that is inadequate fixation. If you do create a gap at the back there, you need to do more robust fixation than what was done here in 1996. And basically, this patient went on to a non-union, and I had to do a bone grafting and a proper posterior fixation. So be prepared for the creation of a gap. And if you don't fix that adequately, just like any gap in the body, it doesn't tend to heal very well. You risk a non-union if you don't deal with it. So in summary, a stable pelvic ring, one that doesn't move, may require treatment for reduction of a deformity. And this is one example of those. An asymmetric lateral compression type of injury can be quite stable, impacted, and the maneuver to reduce and fix that was described. And when do you do this? Well, for me, any clinically apparent leg length discrepancy or internal rotation, it's not going to get better. Remember that lateral compression injuries tend to get worse over time with weight bearing and activity. So what you see day one is possibly going to get worse. It certainly won't get better. So if you see anything clinically apparent, it should probably be reduced and fixed. and you need to distract it. And this is sort of the opposite of what we usually think about, but this requires distraction. And if you do that, just be mindful of a posterior gap that needs to be dealt with. And here's a clinical photo. She was upset that I didn't show her face. She said, how's anybody going to know who I am? And I told her that that was kind of the point of not showing her face. But here she is. This picture is actually not taken at 12 weeks, but earlier on. And I like to keep the fixator on if I can for about 12 weeks and then take it off. So that's the end of that case. Thank you very much for your attention.
Thank you, Hans. That's a fascinating case. We were just commenting, we always hear that term bucket handle injury. I don't think I ever really completely understood it till you explained it in these slides. So it seems like the thing that's unique here is that the contralateral SI joint is basically normal, and it's just crushed to the ramus on the opposite side, as opposed to a typical LC3 type injury where the other side may be open.
Yeah, and that term I think is Marv Tiles, the bucket handle. You know, he had that little drawing there of the bucket, and I think the lateral compression injuries are often not pure, you know, compression from side to side. They can go superior, as in this case, or in other cases the asymmetry can be inferior. So you get medial and inferior asymmetry. So it's just one variant of that. But I think the important point is just don't forget about deformity. When the pelvic ring is stable, you still need to think about reduction and fixation for deformity.
And then Hans, one other question before we'll let Dr. Wright be getting his screen up to be ready to be shared here. But if the opposite SI joint had been open slightly, we still tend sometimes to use a distraction frame in the front. If you start distracting in the front to try to externally rotate the side that's internally rotated, how do you prevent that from externally rotating the side that's externally rotated? And does that require some other?
Well, you'll notice very quickly whether you've been wrong in your assessment of the opposite SI joint, because as you start distracting, it'll distract through the opposite SI joint instead of reducing the deformity. So if that's the case, then you need to have a strategy to stabilize that opposite SI joint first, usually with iliosacral screws. But you need some good fixation of that to distract against, or it'll just open up on the opposite side.
Great, thank you, Hans. There's some questions coming through that I'll let you get busy trying to answer if you don't mind. But thank you very much. It's a great case and very interesting. So the last case presentation will be Dr. Ray Wright from University of Kentucky in Louisville, who I think this is a great case to have the last one because it kind of brings home a lot of the points all the way from emergent management to fixation of a multiple sort of complex pelvic ring. So I think that'll be a good lead into and a good wrap up for what we've learned over the last 3 weeks. So Ray, I'll turn it over to you.
All right, well, thank you very much. And thanks for the introduction. My goals for this case, really, I think Steve, thank you for that. I think to wrap everything together, and mostly for you all to consider the diagnosis, especially fine points of diagnosis in pelvic ring fractures, most especially this one, and really to hone in on imaging details. Sometimes when there's a lot of injuries involved in a pelvic ring and multiple vectors of force and deformity, it can get somewhat daunting. And so I think if you look at these as individual portions and allow for some preoperative planning, it can be really helpful for you and your patient. What I want to highlight in this case especially is that some of the resuscitation maneuvers that we employ can be used to help you with your definitive fixation. I'll show you an example of that. When you have multiple injuries in your pelvic ring, sometimes there's more than one sequence that can be taken, and this just happens to be the one that I took for this particular patient. Maybe we can have a little time to talk about why, and then post-operative plan and rehabilitation for your patient. And so this is a young woman that we took care of just a few weeks ago. She's 24 years old. It came in as a result of a motor vehicle crash. In addition to her pelvic ring fracture, had a right femoral shaft fracture, a left knee dislocation, and also had a left upper extremity fracture, and was hemodynamically unstable upon presentation. A lot of times when I'm talking to acute providers in the emergency department, I think it's very important to hone in on her hemodynamic instability. This is the thing that'll kill her, and a lot of us remember from our basic principles courses that you can apply a sheet or a binder, which I think was really a good example of that in our first talk today. The proper placement of either commercial binders or bed sheets. We use a lot of bed sheets at the University of Kentucky that are sort of smooth and drawn over and centered over the greater trochanters. But we'd provide a circumferential and a shock sheet, and the patient's stability hemodynamically had improved. The patient had finished up her ATLS course and was resuscitated. What I think is interesting in our initial injury film versus our film in the sheet, what you see is that her pubic rib injury, this injury on the left anterior aspect of the pelvis, had become somewhat unmasked. And all the while, her posterior pelvic ring looks a little bit better while she's in the sheet. We had obtained some CT-generated two-dimensional images, which we see here on her inlet view and outlet view on the right. And then while Jade views aren't terribly frequently employed for pelvic ring fixation or planning, I think these are great images to use for preoperative planning, especially if you're planning on using Ramus screws. It can help you to assess the morphology of the anterior pelvic ring. You also get a look right down the sacroiliac joint on both sides. And so I think all that information is good information, even though it's not classically talked about when planning for pelvic ring fixation. I have a few CT scan cuts here, which you can see are in her sheet because you can see her clamps are anterior on her abdomen. You can see some hematoma, which is somewhat displacing her bladder. You can see injury both to the left and right-sided sacroiliac joints. Moving down to the front, we see her injury through her pubic root. She has a groin line that's in place by our general surgery service and her symphyseal disruption. And to pull it all together, I have an injury CT scan here on video. This is showing her in her CT scan gantry, although she's got reduction of the posterior pelvis, presumably due to the sheet, and maybe somewhat to the CT scan gantry, which we talked about a little bit before. You can see some blood in the subcutaneous tissues anteriorly, and the displacement of the bladder by hematoma, which we showed before. So to summarize, her bony injuries, at least, I think she has a complete right-sided sacroiliac joint injury, a disruption of her symphysis pubis, a fracture of her pubic root on the left, and a left SI joint fracture dislocation or crescent fracture, which is really rather small. I think broadly speaking, Dr. Carnacher had what I think we would consider an LC3 injury, and I think maybe this fits reasonably well into that same category also, but with some minor variation between his case or his patient and mine. And so the operative plan, I think in terms of positions, I really like to operate supine as much as I possibly can because it gives access to the entire pelvic ring. And we had talked about sequencing and positions in our first couple of weeks worth of lectures. And so whenever possible, I try to operate patients in the supine position. Implants, I think you have to have some sort of implant to secure the symphysis pubis, both sides of the posterior pelvic ring as well as the pubic root. And sequencing we're going to talk about here in just a little bit. And so I put special considerations, and I think the special consideration that we need to come to is that when we had taken her to the operating room, she was still in her sheet. She was still in distal femoral traction on both sides. And we had taken her sheet off. Her blood pressure had decreased. And so we had put her circumferential and a shock sheet back on, and her blood pressure had gotten considerably better. And so at that point, we had used our circumferential sheet and had cut some working portals in our sheet to apply anterior external fixation, as well as posterior portals for insertion of iliosacral screws. And with the patient positioned on the table with the midline lumbosacral bump and her sheet in place, her hemodynamics were much improved. Because of the left-sided sacroiliac joint injury, we placed an upper sacral segment screw in sacroiliac style to secure the left-sided sacroiliac joint. And then we had applied an anteriorly based frame through our working portals. And the combination of this left-sided sacroiliac or iliosacral fixation with the sacroiliac screw and the anterior frame allowed us to take down this sheet and allowed us to get a more circumferential prep of her pelvic ring. If I were to sacrifice reduction anywhere, I think I would sacrifice reduction anteriorly versus posteriorly, meaning the weight-bearing portion of the pelvis is posterior, and I wanted that to be as perfect as possible without violating this patient too much due to her hemodynamics. And so she had morphology that would accommodate medullary ramus screw on the left, and we had strategically placed our external fixator pin cranial enough so as to allow for a screw to be placed. And so once that screw was placed, we had moved to opening the symphysis pubis. If you look right down in the midline, you see that we have a Youngblith clamp that's applied to the symphysis pubis. I don't use this terribly frequently, but we needed some control of her hemipelvis on that side, in addition to her frame. A single clamp, at least for me, I couldn't make it work with just a single non-screw based clamp, and so we'd applied a Youngblith clamp to that region to help obtain and maintain a symphysis pubis disruption, and then had secured her right-sided sacroiliac joint disruption through a percutaneous approach with a partially threaded upper sacral segment screw. And then we had placed a second sacral segment screw in transiliac transsacral fashion to augment the fixation in our upper sacral segments on both sides. Once that was done, we were able to secure the symphysis pubis with a cranially applied reconstruction plate. So our final construct here with what I think is a reasonable alignment of her overall pelvic ring. Her plate is a little bit crooked anteriorly. There's still a little bit of malreduction through the pubic root. AP inlet, outlet view, some selected postoperative CT scan cuts. You can see her second sacral segment is really rather tight, but adhering to some of the principles that Dr. ROUTT had taught us about iliosacral screw insertion, it allowed us for safe passage. And here's her postoperative CT scan that will allow us to see postoperative implant placement, assess reduction, and allow us to be critical of what we've done. And so to summarize, this is a patient with a right-sided sacroiliac joint disruption, symphysis pubis disruption, left pubic root injury, left-sided crescent fracture dislocation. The aspects and teaching points I'd want the learner to take away from this is that sometimes you can use resuscitative maneuvers to help you with your definitive fixation. We used a sheet and cut working portals in it, and that allowed us to keep the open portion of this pelvic fixation to a minimum. I think when you're fixing a so-called LC3 injury, I think these are really rather challenging fractures to take care of, and creating a stable base or a stable hemipelvis to work back to can sometimes be very tricky. If this patient wasn't hemodynamically unstable, this might be a good time to perform an open reduction. But given her instability and our ability to obtain a reasonable reduction fixation through percutaneous exposures largely, I thought that's why I built the strategy the way that I did. The frame to control the unstable side was to allow us to take off our sheet and get a circumferential prep. And I put here symphysis last. And what I mean by this is if I'm going to sacrifice reduction anywhere, I'd really want it either through the symphysis pubis or what we have through the pubic root, and try to get the posterior pelvic ring and sacroiliac joints as close as possible. And so those are my final points. I'd like to thank you all for your attention and invite any questions that you might have.
Great, thanks, Ray. That's a great case to go through. Brings home a lot of points there. There've been a lot of questions popping up and back and forth. So I'll ask you this. So the question is always for us is trying, first of all, to assess what is an adequate reduction of the posterior ring of an SI joint, and then deciding do we have that, and can we accept what we have? So the question is that some institutions have the 3D CT scanners, you know, the Zeem, and they can use and get a better look at that. Some people don't have that. So that the question here is, is this adequate reduction? Would it be better with an open reduction, or is it, when should we be opening and when should we be happy with that? So it's, yeah, so that's always a hard question for us to answer. So how do you assess it in the operating room and decide this is good enough when you're putting screws in and doing it percutaneously? And then do you have any feelings about what good enough is? Yeah,
I think that's a tough question. We could spend maybe all afternoon talking about that very thing. I'll tell you that in my practice, most of the time that I'm using two-dimensional intraoperative films, intraoperative fluoro, to assess my reduction. And it's this is going to sound a little bit glib, but I think you got to get a good teacher and you got to get a lot of experience to assess that reduction. We talked about some radiographic lines in our first and second weeks, and how to assess that, and I usually adhere to those principles. For me, I think this is pretty darn adequate reduction, even though it was closed reduction for her. I think it's pretty good, pretty adequate, if not good reduction of the posterior pelvic ring. I frequently employ, and when I say frequently, I mean always employ postoperative CT scanning to assess my reductions if they need to be taken out. Occasionally I've used an intraoperative fluorospin or the Zeem if there are questions. That happens to me maybe a couple of times a year where I need to do that. I think the other point is how good is good enough, and gosh, I'm trying to make this at least a couple of millimeters of displacement for me, and is maybe really pushing it. But in a case like this woman, in a case like this woman that we had taken care of, where her hemodynamics were somewhat tenuous, I think you have to give yourself the option of coming back if on your postoperative CT or your intraoperative fluorospin it's not quite right. And a lot of times you have a discussion with families ahead of time and say, hey, we're going to get her today, and we're going to, if her hemodynamics are bad, we're going to try to just get her to the point where her hemodynamics are good. We've got her pelvis in an overall good condition. We'll CT scan or intraoperative spin, reassess, and if we have to come back, we have to come back, but let's do that maybe when she's better resuscitated. Great. I think that's yeah, we could talk about that with forever. All day long. That's a good answer. The only other question I'll ask is, the sheet is a great idea. And we always talk about cutting holes out and operating through holes in the sheet, because that's, but for us, that usually means an angiogram or something like that. It's uncommon that we're actually putting implants in through holes in the sheet. How often do you do that? And that's one of the few cases I've seen where somebody really showed a case where they really did it, you know? And yeah. You know, maybe once a year, twice a year. It doesn't happen that frequently. You know, I've had years where I've done this once a quarter, and I've had years where I haven't had to do it at all. You know, but it's a great tool. It's a really great intraoperative adjunct, and maybe the reason that I like sheets over commercial binders, beyond the fact that I'm exceedingly cheap, is that I can cut holes out of the sheets pretty easily, as opposed to the binders, and kind of the sheets are everywhere too, and nobody gets too upset about blood getting on a sheet, you know, versus a binder, or you making modifications to do something like this, or from a cost standpoint. That's great. It's a good example of working through a sheet that helped you with some of the reduction. If Chip is still on, maybe Chip could comment, because Chip, I think you use the Zeem 3D fluoroscope regularly.
And I just wish maybe you could give us just a 2-minute comment on your thoughts on how you use that and how that's changed your practice, if any at all.
Well, they completely changed everything. It's sort of like the surface rendered 3D images. They give you information that you can't even imagine. So this is just it's just a C-arm, and it's a routine C-arm that we use for all the procedures. But then if we need to assess a reduction either post-op or before we fix it, or we want to look at if the debridement of the joint or whatever is sufficient, the image goes through an arc of almost 360 degrees. You just center up on what you want to see. It takes 42 seconds to go through the process, and it takes about another minute for the software to generate the images. You just scrub out and you scroll through them with the mouse and look and see. And then you can either say, yeah, that's a great reduction, or no, that's a terrible reduction, or I love my implant. Yesterday I did an acetabulum, and when we got through with the spin, there was a piece of bony debris down in the caudal aspect of the posterior capsule that we hadn't seen. And it was as big as about half of my little fingernail. And I just hadn't seen it until the spin, and I could just retract the caudal capsule after it had already been reconstructed and just pull it right out. So it saves us in acetabular injuries as well as the pelvic ring. But it's a great tool to give you real-time under anesthesia information that you can use and make a change if you need to intraoperatively without needing a post-op CT or things like that. So it's transformed the practice, and I think it's made us all very safe.
I think, yes, I think that's a great point. And since we're broadcasting to everybody, I will say that we use the proprietary term Zeem. I shouldn't have done that. I would say there's 3D fluoroscope machines. There are other companies that make a similar type machine that I think Siemens makes one, and
there's a whole bunch of them.
a bunch of companies make them. I think
buy whichever one your hospital will get. It doesn't have, you get whatever one you want. It just it's the information that you need, not the manufacturer.
Right. All right. If the panel want to pop up briefly, we're really out of time, but I just thought before I do my closing slides, maybe the panel could all just make their pictures appear. And if anybody has any parting comments or questions that they'd like to ask before we close, we could probably take about 5 minutes for that. So any parting comments from anybody? I didn't really tee you up for this, so this is putting you on the spot, so good.
I just would say, Steve, I think we're all very happy with the opportunity to be able to teach in this form, and we're really grateful for AO and for all the North American Education Committee for putting it together. And it's a pleasure to be able to do this course when we thought we weren't going to be able to. And I think all of the colleagues feel the same way, that we're happy to be able to be a part of this and to bring this to the audience and to actually expand our audience from the routine. So thank you for having us be a part of it and being able to work in this forum.
Great. Thanks to all you guys for participating. I think the cases were outstanding today. So we'll just kind of wrap up here. And so I just we'll just kind of go through, just remember the cases that we did. I'll just let you reflect back. I'm not going to really harp on them, but we heard a great case from Dr. Jenkinson with this APC2 injury and talked about some important points there. Dr. Stover showed the sacral insufficiency fractures with spinopelvic dissociation. Dr. ROUTT showed his complex sacral fracture with displacement that was ultimately treated with anterior and posterior fixation, including iliosacral screw fixation as well as lumbopelvic fixation. Dr. Carnacher showed a LC3 type injury with a significant soft tissue injury and bladder injury, and went through his thought processes on how to handle the soft tissues. Dr. KREDER showed sort of the interesting case of the bucket handle tear, with bucket handle lateral compression injury. Excuse me, I'm thinking about knee arthroscopy here, and how that was handled. And then Dr. Wright went through this complex case with the bilateral SI joints, the symphysis dislocation, and pubic ramus fractures with the technique for treatment of that. So this is the end of the third week, the end of our discussion of pelvic ring injuries. And I think what we've really tried to cover, and I think what has been covered reasonably well, has been the emergent treatment and hemorrhage control, diagnosis and radiology for a classification of these injuries, the soft tissue management. Our options for definitive treatment included both open and closed reductions, multiple fixation options, and order of fixation if it was anterior and posterior. And we've talked about some of the postoperative management protocols. So We'll remind you that the talks will be on AO Trauma North America YouTube page, and you can sign on to that to see these talks. You'll get a link sent to you if you were registered for this course within 24 hours, where you can sign on to watch these case presentations again, or any of the previous lectures up to this point. That's how you access it. So, and again, just to remind you that this will continue every Saturday, as you heard, and this will go on through the end of August. So next Saturday, we'll start, move past the pelvic ring and into acetabular fractures. And we will have the initial talks next week will be on the acetabular fracture. It'll be the evaluation and some of the initial decision making. And we'll encourage you to sign back on. Hopefully you've enjoyed the first 3 weeks and we'll be able to join us again for the next one. There is a homework assignment for those of you who are interested in preparing for next week's presentations. There's an excellent talk on the radiology and classification of acetabular fractures that will be good to look at ahead of time. And then there is really an outstanding talk on preoperative planning. To kind of take you through an introduction of how to draw a fracture on a pelvic model, which I think is just really critical in understanding the fracture. You should be able to sit down and draw these things out and plan your surgery. So with that, we will wrap it up. We thank you for sharing our passion for this topic, and look forward to hopefully seeing you again next week. Before you sign off, we would ask that you please answer, I think there'll be 4 or 5 questions here regarding evaluation of the course. You'll get a link later on with some more specific evaluation, but we would appreciate it if you could answer some of these questions before you sign off. So thanks for joining in. Thanks for your attention, and we look forward to seeing you next week.